As we start to investigate healthcare costs, it's critical to examine the market forces and incentives that influence the behavior of physicians and hospitals. Simply put, medical providers are more likely to offer a service if it pays well. And because of our fee-for-service reimbursement, providers are paid more as they do more stuff to patients.
What we tend to minimize are those things that would add to the sustainability and, in fact, the better health.
In general, providers are paid well for acute care, like surgeries, procedures, and imaging. But typically providers are not paid as well for wellness care, things like prevention, chronic disease management, and patient education. For instance, many vaccines are reimbursed less than what it costs to administer them. As a result, many pediatricians have stopped offering them.
What we have is really a failure of the current system to recognize the cognitive efforts of physicians. What we do recognize is intervention, imaging, cutting, repair.
Reimbursement rates for medical services have nothing to do with the value of their actual effect on patients. The result of all this is that we don't pay for the services that truly affect population health.
I think when we look at the cost of healthcare that is focused on fixing things when they break, sick care rather than health care, we have a real hypocrisy that arises within our culture, where on the one hand we're saying we will pay for the diabetics' amputation, but we won't pay for their test strips. We will pay for the heart attack, but yet we as a culture continue to eat the Big Macs, to supersize.
We should step back for a moment and ask what factors do have an impact on population health. It turns out that medical services play a relatively minor role when compared to behavioral, cultural, and socioeconomic factors. For instance, 40 to 50% of all premature deaths can be attributable to some harmful personal behavior, such as smoking, obesity, alcohol, or drugs.
Centers for Disease Control had determined on a population health basis that the factors that determine health are roughly 50% behavior and lifestyle, 20% genetics, 20% environmental, and about 10% health services or medical services as they're currently delivered.
The risk of premature death for people at the lowest rung of the economic ladder is 3 times that of people at the top.
Equality and not just absolute level of prosperity contributes to health or ill health, and so the more unequal a unit is, a state, a region, a nation, the worse it is for people's health.
Thus, we must begin to recognize that social policy and health policy cannot be separated.
What types of medical services have the greatest impact on public health? Well, we know that disease prevention and chronic disease management play a critical role. Proper management of diabetes and high blood pressure not only saves money, but it prevents heart attacks and strokes. Colonoscopies and pap smears catch cancers early and save lives.
50% of death is due to diet and lack of exercise. Because there's absolutely no reimbursement for these preventive services, they tend to get left by the wayside. Not because we choose to ignore them, but trying to get everything else done, that tends to fall by the wayside.
Walter Cronkite said, "American healthcare system is neither healthy, caring, nor a system." I think he was onto something. There are a lot of complex pieces to the American healthcare infrastructure. Hospitals, physicians, insurers, and drug companies, just to name a few. The goal of each individual piece isn't necessarily public health. Rather, the goal is to provide a service and to make money. In contrast, other countries have a nationally coordinated system that makes decisions about standards of care, workforce policy, and cost effectiveness.
Even within Medicare, there is very little national coordination. As a result, researchers have found huge variations in spending across different regions for patients with the same disease.
It's pretty well established that the supply of medical services affects medical service utilization. It's sometimes called build a bed, fill a bed.
The most compelling explanation for differences in spending is a term called supply-sensitive care. As the number of medical services, such as intensive care beds, MRI scanners, and subspecialists increase within a region, so does the spending without any change in quality. In other words, where there are more MRI scanners, more MRIs get done. But overall, these extra MRIs have no impact on population health.
You know, most Americans believe that more care is better. But according to researchers at the Dartmouth Institute, surprisingly, patient satisfaction is actually lower and mortality is higher in regions that provide more care.
In terms of the Dartmouth Atlas, looking at very similar kinds of institutions, very similar kinds of treatment protocols for individuals, but yet wide variations in terms of cost. And that is raising some questions as to are we in fact using the best evidence with regard to how we treat disease?
For example, the average hospital in Los Angeles spends $25,000 more per patient in the last 2 years of life than the average hospital in Sacramento.
We have a reimbursement structure that rewards volume. The things that we spend our money on do not have a major impact on the health of our population. This is one of the biggest reasons why we can spend so much more money on healthcare, yet have worse health than the rest of the industrialized world.
Clearly, one of the problems from an economic perspective is where those dollars are spent. Increasingly, those dollars are spent in the first 6 or the last 6 months of life, premature births, and extraordinary interventions at the end of life are consuming significant amount of those dollars. Those are not dollars that go into prevention.
In addition, the American public has an insatiable appetite for technology. And the thing that drives all of this is technology. It drives cost, it drives liability, it drives consumption, it drives volume. And so the crux of all this is technology, even though the technology may not be providing all of that.
So far, we've placed the vast majority of our healthcare resources into the acute care setting and into subspecialty care. We failed to put enough emphasis on the basics of medical care. We're failing to prevent and control the diseases that have a substantial impact on the health of our population. These diseases, like diabetes, high cholesterol, smoking, depression, asthma, and many others, they're not difficult to treat in the early stages. It's only when we fail to address them at the primary care level that they eventually lead to difficult complications that require expensive care.
The real question from the standpoint of cost becomes, do we use the population statistics, which suggest that a certain procedure may not be of benefit, recognizing that it will benefit some individuals? The United Kingdom, Canada, France accept accept their health care coming more globally. In other words, what's best for the total is what's best for the individual. It's not how we think in the United States. It's much more individualistic. So what's better for the individual tends to rule the day. And our cost structures and our healthcare system is built around that.
How can we begin to address this problem? We must commit to reallocating our precious resources towards producing cost-effective, high-quality care for our population. We need a cultural change in American medicine, where we abandon our current strategy of providing sick care and start providing wellness care with a renewed focus on improving the health of our entire community.